So welcome to Inflammatory and Immunity Agents. I'm Sandy Messick, and I'll be teaching this content for you. I want to thank Lori Reiner, who teaches in the evening weekend program, for providing me with this lecture. It really it helps out a lot for a substitute teacher. I want this to be a stress-free learning environment as possible for you. So just remember, if I say something and I emphasize it, tell you to remember it, you might see it again. You probably will, so pay attention. There are no surprises. The material that I cover is what I test on. I want this to be a great learning experience for you, and feel free to reach out with any questions you might have. This is sort of a repeat or a refresher of the material I'll be delivering live in class. So why don't we get started? Let's start with a bit of review from last semester. So what is half-life? Remember that concept? So that's the amount of time it takes for the concentration of the drug to be reduced by 50% in the body, and you can measure this in the plasma. So if we, for instance, administer a drug and we measure the level of it in your bloodstream and it's 100 milligrams, and we test it again 2 hours later and it's 50 milligrams, the half-life of that drug is 2 hours. Remember what affects that. Metabolism and elimination affect the half-life of a drug. So for example, if we have liver or kidney dysfunction, the half-life of the drug is prolonged and less drug is metabolized and eliminated. So there's a chance of toxicity there. And what are the two ways that we eliminate drugs from the body? Through the kidneys, through the urine, and through the GI tract in the feces. But of these two, the kidneys are the major player. What's the peak level of a drug? That's the highest plasma concentration of a drug at a specific time, and it indicates the rate of drug absorption. So if the peak is too low, we don't have an effective concentration, and the patient isn't receiving enough of the drug to have therapeutic effect. And remember that the peak depends on the route of administration. PO is pretty slow, IV is the quickest. And what's a TRO level or a trough level? That's the lowest plasma concentration of the drug, and it measures the rate at which the drug is eliminated from the body. So we usually draw those just prior to the next dose of the medication. So think about vancomycin peak and trough levels. What's the difference between a loading dose and a maintenance dose? Remember, we talked that sometimes we're giving a loading dose as the first dose to get that concentration in the plasma up quicker. And then we drop down the dosage to a maintenance dose. So we keep a therapeutic level of that drug in the body. And remember the difference between an agonist and an antagonist. Drugs that activate receptors on the cells and produce the desired response are called agonists. And drugs that bind to those receptors on the cell but block the response are called antagonists. So drugs can also be nonspecific, meaning that they can also produce an antagonist and agonist effect at the same time. It gets complicated. What's the difference between a side effect and an adverse effect? Side effects are kind of predictable. They can be severe or minor, and they're generally controlled by an adjustment in the dosage. And what are adverse effects? Those are unintentional, unexpected reactions to a drug that occur at normal drug doses. So those can be mild or severe, life-threatening. They're always undesirable, and they really should be reported. And toxicity, that occurs when the drug levels exceed the therapeutic range and may be from drug overdose, either intentional or unintentional. So what is inflammation? What's actually happening in the body when an injury occurs? So inflammation is a response to tissue injury. When there's a vascular response and a fluid and cells such as white blood cells migrate to the injured site. Inflammation is a protective process to where the body attempts to neutralize and establish conditions for tissue repair. Remember, you have all those white blood cells rushing to that area. But what that results in are the cardinal signs that we see on the right-hand side of the slide. heat, redness, pain, and edema. Induration or hardening of an area due to fluid and swelling and potential for immobility because of the swelling and hardening also occurs sometimes. But remember that inflammation and infection are not the same. They have some of the same signs and symptoms, but infection, of course, is caused by microorganisms and an infection to the body, but the body's response is inflammation. The next few slides will show you that they'll be familiar to you. They're probably from what you covered last semester. We're not going to dwell on them a whole lot because you already did them. And so let's just review this really quickly, and you can also review this in your ATI book. So various chemical mediators are released during the inflammatory process, and among those are the prostaglandins. Remember prostaglandins? They have many effects: vasodilation, relaxation of the smooth muscle, increased capillary permeability, and sensitization of nerve cells to pain. COX cyclooxygenase, or COX-1 and COX-2, those are the enzymes responsible for creating prostaglandins. So COX-1 is present in all tissue. It serves as a protective function. It reduces gastric acid secretion, promotes renal blood flow, regulates smooth muscle tone in the blood vessels and also in the bronchial tree. COX-2, on the opposite hand, forms only after tissue injury and triggers inflammation and pain. So they're almost identical enzymes, yet they are doing two entirely different things. So the first generation of NSAIDs, or non-steroidal anti-inflammatory drugs, aspirin, ibuprofen, Aleve, Indocin, they targeted COX-1 and COX-2. So they're not really selective. It's like hitting the whole thing with a hammer. So although it inhibits or interferes and reduces inflammation, what you're doing is also inhibiting the protectiveness of the stomach lining, and also um, can cause bleeding, upset stomach, can actually affect kidney function. So most of the undesirable effects of aspirin and ibuprofen are due to the inhibition of COX-1. So COX-1's got some good stuff going on, and so we don't want to block all of that. So if we can selectively inhibit COX-2, we can make a positive impact on inflammation, pain, and fever. And so that's the newer generation. And of that, there's really only one drug right now, and it's Celebrex or Celecoxib. So remember, you probably see this again. It's important to remember the difference between COX-1 and COX-2 inhibitors, and which is the fact that your non-selective NSAIDs, such as aspirin, naproxen, ibuprofen, and indomethacin, have the potential to cause GI upset and bleeding, whereas Celebrex or Celecoxib does not. So let's start with acetylsalicylic acid. That's a mouthful. Aspirin. That's been around since the late 1800s. It's considered an analgesic. It's also an anti-inflammatory, antipyretic, and antiplatelet aggregate. It's used for pain, arthritis, and stroke, and myocardial infarction prevention by some physicians. And it acts, as you remember from the previous slide, it inhibits the production of prostaglandins. So it's a non-selective COX-1 and COX-2 inhibitor. So remember the side effects of salicylic acid. We also want to remember, as I back up here, that the serum concentration for the unbound drug can be increased by co-use of other medications. So those would include oral anticoagulants, heparins, insulin, some oral anti-diabetic drugs, because these increase the risk of toxicity. And corticosteroids might decrease the salicylic levels, and NSAIDs may have reduced therapeutic effects and increase of GI effects when taken with aspirin. So remember also that we do have enteric-coated aspirin tablets that will lessen the GI effects because they don't dissolve in the stomach. They start to dissolve in the small intestine. So when you're teaching your patients about taking aspirin, the three major points that you want to remember are, number one, avoid alcohol. You might want to inform any dentist or surgeon prior to any surgery if you're taking aspirin because it increases bleeding time. Discontinue the use if you're experiencing ringing in the ears. And again, don't take with alcohol. We do, but before we do cover that, let's remember that we're going to discourage the use of alcohol at the same time and remind the patient that a lot of products that are taken over the counter contain Tylenol as part of the medication. A lot of cold medications, for instance, have Tylenol. So they may be unwaringly giving themselves kind of an overdose and not knowing it. So again, um, it's important to remember, and you'll probably see this again, that toxicity is treated with acetylcysteine or mucimist. So remember that celecoxib or Celebrex is the selective COX-2 inhibitor. That's good stuff. It's an NSAID that selectively blocks that enzyme without inhibiting COX-1, so it's protective of the GI tract. So it produces an analgesic, anti-inflammatory, and antipyretic effect of the other NSAIDs, but without causing platelet aggregation or GI irritation. So the primary advantage of celecoxib is that it causes less GI bleeding and ulcer formation than aspirin or ibuprofen. Let me repeat that. It causes less platelet aggregation or GI irritation and less bleeding from the GI tract, less ulcer formation than aspirin or ibuprofen. There was a previous other drug in this classification called Vioxx, which was an awesome drug. However, there was a higher risk of heart attack and stroke with this drug, so it was actually taken off the market. So again, the selective COX-2 inhibitors cause the same side effects as other NSAIDs, but to a lesser extent, particularly regarding GI bleeding, ulcers, abdominal pain, diarrhea, dyspepsia, and nausea, but it can happen. They've been found to increase the risk of some serious cardiovascular events, including fatal myocardial infarction and stroke. Cardiovascular adverse effects include hypertension, myocardial infarction, and peripheral edema. So remember that patients who take celecoxib are more likely to experience fluid retention resulting in hypertension, but less likely to experience GI effects. Patients who take celecoxib are more likely to experience fluid retention, result in hypertension, and less likely to experience GI effects. And Celebrex is contraindicated in patients with sulfonamide allergies. It is kind of like the last choice for chronic pain due to the increased risk of MI and stroke. So the next classification of drugs that we use to treat inflammation are corticosteroids very commonly. So let's delve into these. Rheumatoid arthritis, or RA. As you all know, it's a chronic progressive autoimmune disease that causes inflammation of the joints. It's characterized by disfigurement and inflammation of multiple joints. And the primary goal of pharmacology is to control this inflammation to reduce the pain and maximize the physical abilities. So we usually begin therapy for RA with NSAIDs, which will reduce the pain and inflammation. But then we use corticosteroids for moderate or severe rheumatoid arthritis. But because of the side effects of the corticosteroids, we always try to use the lowest dose of this class of drug when possible. So the progression of rheumatoid arthritis can be slowed or modified with a diverse group of drugs called disease-modifying anti-rheumatic drugs. DMARDs. Remember this acronym: disease-modifying anti-rheumatic drugs, DMARDs. They have been found to reduce mortality rates, to improve symptoms, and enhance the quality of life in patients with RA. Most healthcare providers prescribe DMARDs within 3 months of a diagnosis of rheumatoid arthritis, and it's not unusual to see several different drugs in this class. Hydroxychloroquine is one of the first DMARDs that is usually prescribed in rheumatoid arthritis. This drug is also used for the treatment and prevention of malaria. And we have seen and heard about it this past year in discussion about COVID-19 and its use there. For full effectiveness, hydrochloroquine is most often prescribed concurrently with an NSAID and steroids. It's important to remember that it takes several months, about 3 to 6 months, until therapeutic effects are achieved. I will repeat that because it's important to remember that it takes several months, about 3 to 6 months, until therapeutic levels are achieved. So if your patient tells you they've been taking a DMARD for a few weeks and they don't feel any better, what would you tell them? You would probably remind them that they need to give it about 3 to 6 months to see therapeutic effects. The primary adverse effects of hydroxychloroquine, they're GI related, but the other possible effects are visual problems. Patients may experience blurred vision or photophobia. They can have blackened visual fields, and these may be irreversible. So this is an important, any change in eye function. So we obtain a baseline eye exam after the medication is started, and then we recommend eye exams every 6 to 12 months. Remember that. The baseline eye exam is obtained right after starting the medication, and then we recommend follow-up eye exams every 6 to 12 months because these impairments to the visual system can be permanent. Another DMARD drug is methotrexate. Methotrexate is used in a lot of different disease processes. It's used in proliferative inflammatory diseases, cancers, leukemias. It's an immunosuppressant. It's used in kidney implants and severe psoriasis and rheumatoid arthritis. It's also used as an abortion drug. It's a folic acid antagonist and an immunosuppressant. The most common adverse effect is GI irritation and stomatitis. We also need to inspect the mouth for sores and a furry tongue. Yes, a furry tongue. So patients should be taught to notify their provider if they notice these things in their mouths. So I'll repeat that. Inspect the mouth for sores or a furry tongue. Kind of looks weird. It's also given with folic acid to prevent GI and hepatic side effects. So we're going to teach patients to use a soft toothbrush to avoid oral and gum irritation. So inspect the mouth for sores or a furry tongue and use a toothbrush to avoid oral and gum irritation. These patients are prone to infection. Some severe adverse effects such as bone marrow suppression, hepatotoxicity, pneumonitis can occur. We're going to monitor CBC, liver and kidney function tests, especially BUN and bilirubin. We need to teach patients to report cough, extreme fatigue, sore throat, chills, fever, and prevent exposure to individuals with infections. We tell them to take the medication with food or 8 ounces of water. We'll talk a little bit about gout as well, because it's an inflammatory disease. It's a form of acute arthritis, actually, that's caused by an accumulation of uric acid crystals in the joints and other body tissues. The kidneys are normally responsible for excreting uric acid, but high levels of uric acid in crystals that can't be excreted can gather in this joint space and cause swollen and inflamed joints. These crystals are exquisitely painful. If you've ever seen a patient with gout, it's not a sight that you would really forget anytime soon. You see a lot of this in emergency departments. So the primary diagnosis of gout, not only through the physical presentation of that joint pain, is high levels of serum uric acid. So you have hyperuricemia. So again, the kidney can't excrete it for whatever reason, and these crystals accumulate in the joints and cause intense pain. Um, it's usually sudden in onset. It's kind of scary, and the sites are usually the sites that are affected are usually the big toes, the heels, the ankles, the wrists, fingers, knees, or elbows. And what you'll see is exquisite pain, redness, inflamed tissue, and sometimes, but not always, you might see some fever associated with that as well. And so the treatment for that is allopurinol. It's the mainstay of gout therapy. It's a uric acid inhibitor, and it blocks the accumulation of uric acid in the blood or uric acid crystals within the joints. So when uric acid accumulation is blocked, then the symptoms associated with gout will diminish. The drugs are most effective if taken within 12 hours in an acute attack. It's also useful in patients with renal obstructions caused by uric acid stones. And so if you initially see elevated BUN and creatinine levels, are you concerned? Yes, absolutely, because you do not want them to continue to climb. So it's important to teach patients to increase their fluid intake to 2 or 3 liters per day to promote excretion and reduce the risk of urate crystal formation. And we also want to report any decrease in urinary output. So let me repeat that. If you initially see an elevated BUN and creatinine levels, you are concerned because you don't want them to continue to climb on this medication. It's important to teach patients to increase their fluid intake to 2 to 3 liters per day to promote the excretion of this medication and reduce the risk of urate crystal formation. Patients should also avoid alcohol and foods high in purines, such as salmon, sardines, legumes, which include like alfalfa, clover, beans, peas, chickpeas, lentils, soybeans, peanuts. Also mushrooms, oatmeal, and organ meats. This used to be considered a high-class disease in the days because it was associated with the kind of foods that were expensive. And so that's why we include some of these food risks. Keep in mind when doing your teaching, the patient should realize that the gout pain they experience, it shouldn't get worse, but it should start to subside gradually. If they have increased pain, it could be a sign of something else going on. Colchicine was the very first drug that was used to treat gout. It's specifically effective in alleviating acute symptoms of gout, but not effective for decreasing inflammation that occurs in other inflammatory disorders. It doesn't inhibit uric acid synthesis or promote uric acid excretion, and it should not be used in patients with severe renal, cardiac, or GI problems. GI problems are a common side effect, so patients should be taught to take colchicine with food. So now we're going to talk a little bit about antivirals. Most antiviral medication acts by altering viral reproduction. So these medications are only effective during viral replication, and they don't work if the virus is dormant. For instance, HIV is a retrovirus. So a retrovirus is a type of RNA virus that inserts a copy of its genome into the DNA of a host cell that it invades, and it thus changes the genome of that cell. These viruses must attach to a host cell in order to replicate. Antiretroviral agents are used for treating HIV patients, for example. They don't cure or prevent passing the disease to others. They prevent the virus from entering the cells or inhibiting HIV replication. According to the National Human Genome Research Institute, a retrovirus is a virus that uses RNA as its genomic material. Upon infection with a retrovirus, the cell converts the retroviral RNA into DNA, which in turn is inserted into the DNA of the host cell. The cell then produces more retroviruses, which infect other cells. Many retroviruses are associated with diseases, including AIDS and some forms of cancer. And this slide is just an overview to show the large variety of viruses that are out there. And these viruses can attack any part of the body. Ganciclovir, another anti-retrovirus medication, is used to treat and prevent cytomegalovirus in patients. So or CMV, cytomegalovirus, boy, I'm stumbling over that. Cytomegalovirus is a common virus that in most of us doesn't show any signs or symptoms. Once you're infected, your body retains the virus for life. It rarely causes problems in healthy people. If you're pregnant or if your immune system is weakened, CMV is a cause for concern. So we also give the medication ganciclovir for herpes simplex, and especially in patients with HIV, organ transplants, or if they're immunocompromised. Patients need to complete the treatment regimen even if the symptoms resolve. We administer it via pump over at least an hour. If it's the PO version, we administer it with food and encourage additional fluid. We avoid getting the solution or the powder of the medication on your skin. It can be toxic a little bit, so wash it off. Effectiveness is evident with improvement of lesions and decreased pain. When cytomegalovirus symptoms occur, they're usually similar to, say, mononucleosis. You have fatigue, you can have low-grade fever, chills, sweats, muscle aches, decreased appetite, enlarged lymph nodes, and sore throat. Enfuvertide limits the spread of HIV by blocking HIV from attaching to the T cell. It's usually used when HIV doesn't respond to other antivirals. HIV antivirals don't kill the virus, remember. The purpose is to reduce HIV-associated morbidity and mortality, prolong the duration and quality of life, and prevent transmission and restore and preserve their immunologic functions. Enfuvertide is given sub-Q. We rotate the injection sites. We monitor for local irritation, redness, and swelling. Clients that are breastfeeding should not take this. It can cause bacterial pneumonia, so we're going to check the respiratory status for signs of pneumonia, such as fever, cough, shortness of breath, as well as lung sounds. We want to do this prior to beginning medication as a baseline and then continuously while the patient is being treated. It's important for you to remember that these patients should be monitored for localized erythema, redness, itching, and bruising, signs of pneumonia, and signs of hypersensitivity, which would include hypotension, rash, fever, and chills. Ritonavir is a protease inhibitor that acts by altering and inactivating the HIV virus by inhibiting the enzymes that are needed for its replication. It's usually combined with one or two other medications to increase their effectiveness in the treatment of HIV. It can have interactions with other medications. It's administered orally, and it's used cautiously in patients with liver disease, pancreatitis, diabetes, and hypercholesterolemia. Patients should eat a diet high in calcium and vitamin D to prevent bone loss. Monitor those with diabetes for elevated blood sugar levels, and we want to monitor for rash, including hypersensitivity and hyperlipidemia. So remind patients, take with food to prevent GI upset. Avoid grapefruit juice as it can decrease its metabolism. It can alter the effectiveness of oral contraceptives, so we want to use an alternate form of birth control. It can increase medication levels of the ED drugs for men, such as Viagra. It Different physicians utilize different indications and treatment plans for these HIV patients. Treatment is often controversial. HAART stands for highly active antiretroviral therapy. It's used for HIV treatment, and it consists of using 3 or 4 HIV medications in combination with other antiretroviral medications to reduce medication resistance, adverse effects, and dosages. The number one thing to remember that is very important is that adherence to the medication regime is imperative for success of the therapy. Patients are required to take medication dosages at the same time every day without missing a dose. A 95% adherence is required for it to be effective. Again, patients are required to take the medication dosages at the same time every day without missing a dose. A 95% adherence is required for it to be effective. Missed doses can promote medication resistance and treatment failure. It's highly effective treatment, however, and it can reduce the viral load to virtually zero. And remember, when you get to a zero viral load, you can't transmit HIV. So 2 examples: PrEP, which stands for pre-exposure prophylaxis. So for folks that are becoming sexually active, particularly with multiple partners, highly recommend PrEP to prevent the exposure to HIV. And if it's a little bit too late, PEP stands for post-exposure prophylaxis. It's not quite as effective, but still it's better than nothing. And think of it as kind of a plan B for HIV. Ribavirin is used to treat RSV, respiratory syncytial virus. It's used in more severe cases along with steroids and bronchodilators. It's used for hepatitis C virus when used with other medications. It's administered orally or via an aerosol treatment, and it's contraindicated in pregnancy. Interferon is used to treat hepatitis B and C. It's administered IM or subcutaneously. Both require monitoring of renal and hepatic function. Course of treatment should not be stopped until it's completed, or transient exacerbations or viral hepatitis can occur. Side effects vary and range from mild to severe and can include rash, anemia, depression, fatigue, anorexia, and photosensitivity. Hepatitis C is considered cured if the virus is not detected in your blood when measured with a blood test 3 months after treatment is completed. This is called the sustained virologic response, and data suggests that you will stay virus-free indefinitely. Oseltamivir and zanamivir are the 2 most common medications on the market for influenza A and B. They are neuroimmunidase inhibitors, which mean they decrease the release of the virus from infected cells, thus decreasing viral spread and shortening the duration of the flu symptoms from the normal 7 days to about 5 days. Adverse effects are dizziness, headache, insomnia, fatigue, nausea and vomiting, and diarrhea. Oseltamivir is given PO and zanamivir is given via inhaler. It should be given within 48 hours of onset of symptoms, and teaching should be that oseltamivir can be taken with or without food, and if on bronchodilators and taking zanamivir, the bronchodilators should be taken first and used cautiously as it can cause bronchospasm. In rare cases, abnormal behavior, thoughts of self-injury, and delirium can occur with oseltamivir. In October 2020, the FDA approved the antiviral drug remdesivir to treat COVID-19. The drug may be used to treat adults and children aged 12 or older and weighing at least 88 pounds who have been hospitalized for COVID-19. Clinical trials suggest that in these patients, remdesivir may modestly speed up recovery time. It is a broad-spectrum antiviral medication that's administered via injection into a vein. Tuberculosis is caused by the acid-fast bacillus Mycobacterium tuberculosis. The bacteria usually attacks the lungs, but TB bacteria can attack any part of the body, such as the kidney, the spine, and the brain. Not everyone infected with TB bacteria becomes sick. TB is highly communicable in close spaces. It's spread by aerosol transmission, coughing, and sneezing. Airborne precautions, negative pressure rooms, and N95 masks are required when caring for these individuals. Antitubercular drugs treat persons with TB and those exposed to TB. The pharmacology of TB differs from that of other bacterial infections because of the thick acid layer surrounding the mycobacterium. This is resistant to penetration of most anti-infectives. Therefore, therapy is much longer and continues for a minimum of 6 to 12 months. There are two categories of antitubercular drugs. The first line of drugs or core drugs that treat the first phase of the disease, known as the initial or induction phase. This is when the actively dividing mycobacterial cells are killed. The second phase is the second line therapy or continuation phase, where bacterial resistance is decreased. So we have combination therapy during tuberculosis is often used to avoid resistance. So when treating TB, it's most common to see 4 different medications used. This decreases the chance that the bacteria will become resistant. Single drug therapy is not effective in the treatment of TB disease due to drug-to-drug resistance, and the remaining dormant mycobacteria are eliminated. Persons with latent TB infections are not infectious and can't spread the disease. Without treatment, about 5 to 10% of infected persons will develop TB disease at some time in their life. You can see the differences as described in the slide. One other difference is that latent TB patients have normal chest x-rays and a negative sputum test, whereas patients with TB disease have an abnormal chest x-ray or a positive sputum culture. Quantiferin gold and skin tests can be positive in latent TB. Further evaluation is necessary to determine active TB, sputums, x-ray, history, and assessment of symptoms. Antitubercular medications treat patients with the TB disease and those exposed to TB. Isoniazid, or INH, is the first-line treatment for TB. Isoniazid is the #1 drug of choice for family members and healthcare workers who were exposed to patients with TB before treatment was started. Let me repeat that. It is the #1 drug of choice for family members and healthcare workers who were exposed to patients with TB before treatment was started. It's considered an antimycobacterial or antitubercular medication. It can be given PO or IM. There are many drug-to-drug interactions with this medication. You should not take it with aluminum acids such as Amphogel, Gaviscon. Food decreases the rate and extent of the absorption, particularly foods rich in histamine, tyramine, and caffeine. Those can increase the effects of INH. Foods such as aged cheese, tuna, overripe fruit, avocados, smoked meats, and fish, soy sauce, and yeast. When we have somebody on INH, we want to monitor liver enzymes, AST, ALT, and bilirubin, because INH increases these levels. Remember that the #1 adverse effect of this drug and many other antitubercular drugs is hepatotoxicity or liver toxicity. Remember this, the #1 adverse effect of this drug and many other antitubercular meds is hepatotoxicity or toxicity of the liver. Rifampin is another antitubercular medication, usually used in combination with other antitubercular medications. It should be taken on an empty stomach, but the capsule can be opened and mixed with applesauce or jelly. The medication turns body fluids orange, and contact lenses may be permanently discolored. That's weird, huh? It is a normal side effect and it's not harmful. There are other medications used less often, some newer and some older medications as well. But remember, in order for any of these treatments to be effective, it's important that patients know they cannot skip a dose. Often patients are given several anti-TB drugs. They do this to reduce the chance that the bacteria will become resistant. I'll repeat that. Remember, in order for any of these treatments to be effective, it is important that patients know they should not skip doses. Often patients are given several different anti-TB drugs to reduce the chance of the bacteria will become resistant. And remember also that this drug is given for 6 to 12 months. It's important not to miss a dose. When patients come in every day to receive it, they can have a caretaker in charge of them taking it. So adherence is very important here. We'll talk about vaccinations and immunizations a bit. Remember that vaccination and immunization are terms that are often used interchangeably. But it's important to remember that immunization is the desired response of a successful vaccination in which the person actually develops immune resistance to the substance in the vaccine. Vaccines involve the administration of a small amount of antigen, which will induce the host to stimulate an immune response. The immunization does not typically produce the disease. The antigen in vaccines may be produced in several ways. Traditional vaccines contain the whole or components of an inactivated microorganism. Other vaccines have attenuated viruses composed of live, attenuated, or weakened microorganisms. And toxoids are inactivated toxins that can no longer produce harmful disease, but they do stimulate the formation of antitoxins, which produce active immunity. Different types of vaccines obviously are available, and remember, a desired response for vaccinations is immunization. So as an overview of the different types of vaccines, we have traditional or inactivated vaccines. These contain all the components of inactivated microorganisms. So an example would be pertussis and polio vaccines. Other vaccines have attenuated viruses. These viruses are live, but they're weakened microorganisms. So an example here would be the TB and the measles vaccine. Remember here that people who are immunocompromised in any way should avoid live vaccines. People that are immunocompromised in any way should avoid all live vaccines. And then we have toxoids. Those are inactivated toxins that cannot produce harmful diseases, but do stimulate antitoxins to form, causing passive immunity. So an example would be tetanus. And we have recombinant vaccines. These involve the insertion of some of the genetic material, for example, the DNA, of a pathogen into another cell or organism, where the antigen is then produced in massive quantities. These antigens are then used as a vaccine in place of the whole pathogen. An example would be the hepatitis B vaccine. We now have new vaccines called conjugate vaccines, which require a protein or toxoid from an unrelated organism to link to the outer coating of the disease-causing microorganism. No matter the composition of the vaccine used, the vaccine is designed to stimulate an immune response against a specific pathogen. The body can obtain immunity in different ways. Active immunity occurs when the body's own immune response is stimulated by an antigen or when a pathogen enters the body and produces antibodies against a foreign substance. Antibodies are also called immunoglobulins. The pathway of immunity is slow sometimes, taking days to several weeks, but it is often long-lasting. Natural acquired active immunity occurs when the body is introduced to a pathogen or a disease. An example, exposure to chickenpox. then develop the disease and recover. Active acquired artificial immunity occurs when a weakened antigen or immunoglobulin is injected into an individual as a vaccination, which will then produce an immune response. When an individual is unable to make antibodies and memory cells, antibodies are given from another source to provide passive immunity. This can be done in a natural way, in which case the body produces its own antibodies, or it can be acquired, that is, it receives antibodies from an outside source. Either way, immunity is immediate but short-lived. One way natural acquired passive immunity occurs is by a mother passing antibodies through the placenta or into breast milk to the infant. The infant are unable to protect against disease because of their immature immune system, and they require antibodies from an outside source through the mother. Artificial acquired passive immunity can be given by giving immunoglobulins against a certain disease. Remember, passive immunity is essential when, one, there isn't enough time to permit active vaccination alone, or number two, when the exposed individual is at high risk for complications of the disease, or number three, when a person may be immunocompromised and is unable to produce antibodies and effective immune response on their own. Again, passive immunity is essential when there isn't enough time to permit active vaccination alone, when the exposed individual is at high risk for complications of the disease, or when a person may be immunocompromised and unable to produce antibodies and effective immune response on their own. Even a small number of unvaccinated people can make it much easier for a disease to spread and survive. There's a concept in science called herd immunity, which refers to the idea that a lot of people need to get a given vaccine, whether it's for the flu or measles, to stop a disease from spreading. Vaccinated people essentially act as barriers to outbreaks, since diseases can't pass through them and infect others. The barrier helps protect some of the most vulnerable populations, infants under 12 months of age who can't get vaccinated and more susceptible to infection, the elderly who have a higher risk of death if they contract vaccine-treatable illnesses, and people with compromised immune systems who can't get vaccines and are more likely to die from the diseases they protect against. The threshold for herd immunity depends on the disease and how it's transmitted. In an analysis of several vaccine-treatable illnesses, the Centers for Disease Control and Prevention set the lowest threshold of vaccine coverage at 75%, kind of like in mumps, and the highest at 94% for measles, for example. Even the low-end threshold requires at least 3 in 4 people to get vaccinated. The public health goal is to vaccinate everyone who's able, so there's herd immunity for all vaccine-treatable illnesses. Over time, this would eradicate dangerous diseases, specifically those that are exclusive to humans, by stopping them from spreading and developing in human hosts. We've had some success in this, particularly with polio and smallpox vaccines. There are a few absolute contraindications for the use of vaccines. Caution must be used in immunocompromised patients, such as those with cancer, recent tissue transplants, or those infected with HIV, patients receiving high-dose systemic corticosteroid therapy, because they may also have a suppressed immune systems. In pregnancy, most vaccines are pregnancy category C, which means that the benefits often outweigh the risks to the pregnancy, although sometimes vaccines are delayed in pregnant patients until after delivery to avoid any potential harm to the fetus. The most common adverse effects of vaccines are pain, swelling, and redness at the injection site. Allergy and anaphylaxis following vaccination is extremely rare. Universal immunization is a national goal. If a child gets the complete schedule of vaccinations, they'll receive a total of approximately 32 vaccinations. Vaccines for Children is a program in Pennsylvania which offers free vaccinations for children who are underinsured or lack of insurance. Vaccines maintain health by preventing disease. There are more than 20 diseases that can be prevented by active immunization. This is a great slide that shows the schedule for childhood immunizations from birth to 18 years of age. There's a lot of them. Before immunizations are administered, we screen for medical conditions that may put the child at risk, such as the use of prescription drugs, including over-the-counter drugs, herbal preparations, and any food or other allergies. So we want to take note of the orange box here, the HPV box, which stands for human papillomavirus. It's one of the more recent immunizations recommended. At age 11 to 12, it consists of 3 doses for Gardasil for the prevention of cervical and testicular cancer, to be given prior to the onset of sexual activity. One very important aspect of patient education with these vaccines is that you must provide literature about the vaccine and also include information on when the individual should return for the next dose. It's necessary to complete the treatment regimen or it's not so effective. So the patient needs to know that, and the best way to do that is to provide them with an appointment for the next dose. So these are some immunizations that give us active immunity against bacterial infections rather than viral infections. First example is diphtheria. Tdap, it's offered to parents when the baby is born. It's an upper respiratory infection caused by the toxin of a gram-positive bacteria. Diphtheria causes a thick mucus covering the posterior pharynx, and this causes respiratory distress. The diphtheria toxin that we give, Tdap, triggers immunity without producing the disease. The next one, pertussis, also known as whooping cough. It's a bacterial infection as well. Consists of a low-grade fever and spasmodic coughing. It's called the 100-day cough. Leads to gagging and vomiting. The vaccine is given when the diphtheria vaccine in children receive 5 injections. An important thing to remember about pertussis is that there are cyclical outbreaks every 3 to 4 years. And if we stopped pertussis immunizations in the US, we would experience a massive resurgence of pertussis disease. Remember, there's cyclical outbreaks every few years. If we stop pertussis immunizations in the US, we would experience a massive resurgence of pertussis disease. Adults should be vaccinated to prevent transmission to children. Tetanus lives in spores found in the soil. This toxin is one of the most toxic known. It's lethal even at small levels. It causes continuous painful muscular contractions, commonly known as lockjaw, causes seizures as well. There's been an increased number of tetanus cases in younger persons, especially among intravenous drug users, particularly heroin users, and we need these boosters every 10 years. Pneumococcus is strep causing otitis media, middle ear infections, but it can cause meningitis and pneumonia. Often occurs in winter or following a virus. There's 2 types of immunization, PPV, also known as Pneumovax 23 for kids older than 2 years old, and PCV, which is given at 2, 4, and 6 months. Meningococcus is highly virulent. Its symptoms include nuchal rigidity, headache, photophobia, seizures, and rash. It has a 10% mortality rate and a 20% morbidity rate. And immunization is usually given at age 12, and it's required for college students, most usually for those living in a dorm. Now, when we talk about immunizations for viral diseases, we can start with hepatitis B. Most people can become a chronic carrier of hepatitis B. It can lead to cancer or cirrhosis of the liver. And healthcare workers have a 10 times risk of getting hepatitis B, usually because of fluid exposure, blood stick, needle stick injuries, etc. 100 million people have received hepatitis B vaccine. It's routine in children and newborns. Usually the first dose is given immediately after birth, and it consists of 3 doses. Hepatitis A, usually not as severe. It occurs when there's contact with the stool of an infected person. 1/3 of the US population is immune due to previous exposure. It's also commonly obtained from shellfish that are in polluted waters. Both hepatitis B and hepatitis A vaccines are made from yeast cells. An allergy to yeast would be a contraindication. Remember, at this point, there's no vaccine for hepatitis C yet. Again, both hepatitis B and hepatitis A vaccines are made from yeast cells. An allergy to yeast would be a contraindication to these vaccinations. And remember that there's no vaccination for hepatitis C yet. Influenzas, uh, commonly known as the flu, caused by influenza viruses type A, B, or C. Type A is also known as bird flu, and it's the most dangerous. Um, Immunizations can be PO or nasal. Someone with a hypersensitivity to penicillin would be a candidate for the nasal spray. The influenza vaccine is given to everyone over 6 months. If immunocompromised or around anyone that is, they must have clearance by a physician to receive the immunization. Rabies is carried in the saliva of infected animals. Most people aren't vaccinated because there's a small risk of getting it. Measles, very contagious. More than 90% of people who are not immune will get measles if they're exposed to the virus. Humans are only responsible for the virus. There's about 100 cases reported per year today. If we stopped immunizations, there would be about 2.7 million deaths per year worldwide. Mumps affects the parotid salivary glands. Complications are swelling of the testes in males and deafness. 2 doses are more effective than one. Rubella or German measles is a mild infection, and the main risk occurs if someone who's in the first trimester of pregnancy um, gets rubella. Polio spread via the oral fecal route in contaminated food and water. In about 1% of the cases, it leads to flaccid muscle paralysis. Since 2000, the inactive polio virus has been given, and all polio has disappeared from the US. Global eradication is close and is possible. Varicella, chickenpox, causes a blistered rash with itching, fever, malaise, and anorexia. This goes into the spinal nerves where it can lay dormant for 30 to 40 years and eventually cause herpes zoster or shingles. People born before 1980 are considered immune. Shingles vaccine is given to adults 60 and above. It's essentially a booster of the varicella vaccine. But we don't give this during pregnancy or anyone that is immunocompromised. It may be considered in children with HIV. Patients that are immunosuppressed or on corticosteroids, you always question administering a vaccine. And never give this to a child with a severe allergy to neomycin. Human papillomavirus, we talked about that a little bit before. It's the most common sexually transmitted disease in the US that leads to cervical cancer in women. It's spread through sexual contact. Gardasil is offered to boys and girls 11 to 12 years old, ideally before the onset of sexual activity. The most major side effect for the HPV or Gardasil vaccine is syncope following administration of the injection. Rotavirus is the stomach flu, so we know it's vomiting, diarrhea, low-grade fever, risk of dehydration, and we have oral vaccines that we can give for children 2 to 6 months old. So when administering any vaccine, what vital sign would make you stop and question administering it? I would say probably a temp of greater than 101. And if a child with HIV is ordered to receive an immunization, would you question it? Well, you better, because they're already immunosuppressed. You definitely want to question that order. And remember that after any immunization is administered, you always give the patient this information sheet about the immunization. And remember, it should be in their dominant language, which they can understand. Passive immunity is very different from active immunization. Whereas active immunity requires activation of the patient's immune response and leads to the development of memory cells, passive immunity is the administration of preformed antibodies, what we call immunoglobulins. Passive immunity is typically used to provide immediate protection against a recent infection or potential infection or a disease in progress. Passive immunity is for someone exposed to a virulent pathogen because they do not have enough time to form their own antibodies. So, for example, a student nurse has learned that she's been exposed to blood from a patient with confirmed hepatitis B virus. The student nurse wants immediate protection, and she has not had the hepatitis B vaccines series. So the student will receive hepatitis B immunoglobulin along with the first dose of the hepatitis B vaccine. So this is done because the use of the vaccine requires a little bit too much time for the activation of the immune response, and the disease would have the opportunity to create the illness. This is also done if anybody has been exposed to rabies. So immunoglobulins provide individuals with passive immunity. So a second indication for passive immunity is for situations where the activation of the immune response is not desirable. In this case, the individual is given the antibodies against the foreign and the immune system does not mount a response. So an example would be RhoGAM. Now, RhoGAM occurs when an Rh negative mother is carrying a fetus that could potentially be Rh positive. So the mother without that surface antigen, that rhesus antigen on her blood cells, would recognize those surface antigens on the fetus's blood cells, and her body would mount an immune response, in this case against the fetus. Obviously, that is not desirable. So the only good thing about that is during the current pregnancy, it's unlikely that the disease could progress fast enough to harm that current fetus, although it has happened. But what we want to do is protect her next pregnancy. And it gets a little bit complicated in the cases of uh, uh, abortions or miscarriages or things like that, where sometimes the patient doesn't even know that they're pregnant or they have an early pregnancy loss. So in that case, we give RhoGAM. It's given only to Rh negative moms. I'll say that again. It's given only to Rh negative moms, and it produces antibodies against the Rh positive blood and prevents immune sensitization. And this is to prevent future pregnancies. Again, RhoGAM is given only to Rh negative moms. RhoGAM produces antibodies against Rh positive blood and prevents immune sensitization to prevent against further or future pregnancies. This is kind of a good news and bad news kind of slide. So when we talk about bioterrorism, we're talking about using certain disease processes as a weapon. And for some of these, we have vaccines available, and for some, we don't. The ones available are for anthrax. Um, again, anthrax is commonly carried in animals, but it's easily transmitted to humans by direct contact or by consumption of a diseased animal's flesh. It affects the respiratory, GI systems, and the skin of human beings. It's often lethal, but the good news is there is a vaccine for it. Smallpox, referred to as speckled monster disease, we've had recorded cases of smallpox as far back as 10,000 BC. It's caused by the variola virus, and it's spread through the air. Um, Smallpox became eradicated from the world in 1977 through stringent vaccination programs. The U.S. ended routine smallpox vaccinations in 1977. So if you check somebody's arm who's my age or older, you might actually see the smallpox injection site. It wasn't actually an injection. They scratched the skin with the immunization, and it did leave kind of like a lifelong scar. Um, we don't have vaccines available for plague. That can be spread in the air by direct contact or by contaminated undercooked foods or materials. Example would be the bubonic plague, which travels through the lymph system. There's a septicemic plague, which is carried in blood vessels. There's pneumonic plague in the lungs, and so forth and so on. Plague is still endemic in some parts of the world, but as of yet, we do not have a vaccine against that. Tularemia is caused by rabbits and other rodents. The bacteria can penetrate into the body through damaged skin and mucous membranes or through inhalation. You can also get it through tick bites or handling an infected animal. Botulism, it's a rare but serious paralytic illness caused by a nerve toxin that is produced by the bacterium Clostridium botulism. And all forms are a medical emergency. We do have an antitoxin for botulism. There is no vaccine available for Ebola or viral hemorrhagic fever. That's a virus causing fever, throat and muscle pains and headaches, nausea, vomiting, and diarrhea, decreased functioning of liver and kidneys. The whole system shuts down, and patients actually bleed out as well. The disease is first acquired in a population where a person comes in contact with the blood or body fluids of an infected animal, such as a monkey or fruit bat. But once infection occurs, the disease is spread from one person through another through direct contact. Disease has a high death rate, often between 50 and 90%, and Ebola outbreaks are among the most severe in recorded history. As of 2016, I think the World Health Organization reported a total of 28,652 suspected cases and over 11,000 deaths. So I want to thank you all for hanging in there with me all this time. I am not the best reader and lecturer, but I think this information, if you pay attention to what I ask you to focus on, you should be okay as far as testing purposes. So remember that. Remember, if you have any questions, see me at class or after class or before, or email me, and I would be glad to respond. I hope I didn't confuse you at all, and we'll see you in class.